Good afternoon. Welcome to Grand Rounds today. As I always do, I'll remind you to fill out the attendance record and also to please fill out the program evaluation. And if you could give the CME committee ideas in regards to future topics or future speakers, we always appreciate that. Our speaker today is from the Mayo Clinic. His name is Dr. Manpreet Mundi. He is an endocrinologist. He did his postgraduate training at Southern Cal, and he's currently assistant professor of medicine at the Mayo Clinic. He has been extensively published, and he's been the recipient of several honors, including a House staff teaching, or outstanding House staff teacher, which I think is a real honor. He's here today to discuss medical nutrition therapy in the elderly, and please join me in welcoming Dr. Mundi.
Okay, thank you. Well, thank you for having me, and I'll get started. And I'm hoping to spend about 45 minutes. And can everyone hear me okay? Is that fine? Perfect. So I don't have anything to disclose, and what I'm hoping to do is spend about 45 minutes talking about a topic of medical nutrition therapy, and I'll try not to use the word elderly. We'll just say those above 70, because these are the patients that we are going to see in our clinic over the next few decades. And we really need to develop strategies pertinent to them. And so what I'll do is I'll spend the first maybe 10, 15 minutes focused on the current obesity trends, especially in this population. Then switch to some of the other topics that are really pertinent to the elderly, including obesity paradox. There's a great deal of data out there showing that if we have these patients lose weight, perhaps it's not the best thing for them, and perhaps it worsens mortality. So I'll go more into that. And then finally, I'll finish with some of the medical nutrition therapy recommendations that we can make, including what the data is available in terms of pharmacotherapy and bariatric surgery. So with that, I'll start with this slide, and you've probably all seen this at least 1,000 times by now, but I just think it's so important to go over what we've really accomplished as a nation over the last 20 years. And if we look right here, in the 1990s, you can see that many of the states were not even capturing this data. The states that were capturing this data were seeing about 1 in 10 individuals who had a BMI more than 30. Some of the states, the southern ones, were starting to see 10 to 14%. Fast forward 10 years, you can see now many of the southern states, we're looking at 1 in 5 individuals is obese or has a BMI greater than 30. Other states are not that far behind, 15 to 19%. Another 10 years and you truly see how devastating this is starting to look. Many of the southern states now, well over a third of the population has a BMI greater than 30. Colorado was the last holdout. In 2010, it finally crossed over that 20% mark. So now you've got every state in the union has at least 1 in 5 individuals that are obese, with overall, we're looking at about a third. And so with this, we are the reigning champion amongst all, Western developed countries. We're falling behind, in math and science, but this one, I don't think we'll give up this title yet. And if we project some of the current data out to the next few decades, we start to see, and this is data regarding overweight individuals, and you can start to see that currently about 2/3 of our population is overweight or has a BMI between 25 and 30. This is expected to increase in just the next 8 years to 3/4. So pretty dramatic. But it's obesity where we start to almost panic. We see, and this is data from the same study showing, this is US men, US women, United Kingdom men, United Kingdom women, because they're not that far behind. But currently, we're looking at about a third of the overall population is obese. This is expected to rise to about 50% by 2030. And this is what's the most disheartening. And this is what we're seeing in our practice and in clinical practices all over the country. where we're having to make significant changes to just our beds, to our apparatus, to our CT scanners. And the reason is the fastest growing segment of our population are actually those individuals with a BMI more than 40. So the last decade has seen almost a 50% increase in those with a BMI more than 40, a 75% increase in those with a BMI more than 50. So this is dramatic. And the trend, when we start to then tease out this data based on age, is also quite concerning, because the baby boomers are having a very similar sort of exponential growth in obesity, and they're the ones who are going to turn in their 50s, in their 60s, 70s, and so on over the next few decades. So these are going to be our core patients. And this study really teased this out quite well. You can see what a difference, depending on which decade you're born, makes in terms of your prevalence of obesity. So if you're born between 1911 and 1920, by the time you're 70, there's about a 20% prevalence of obesity, or percent are obese. If we look at the 30s and 40s, it's dramatically different. And by the age of 70, we're looking at about a percent obesity rate in the 40s. And this I'll go through quickly, but I think it's important to show how closely this is tied into all the comorbidities, such as diabetes. And this is looking at about 82,000 women and trying to understand what's the biggest risk factor for the development of diabetes. And of course, the biggest risk factor was your BMI. And you can see this almost exponential increase in those beyond a BMI of 30 in terms of developing diabetes. Same thing, this is NHANES data that showed similar rises in terms of hypertension, in terms of hyperlipidemia. And when you put diabetes, hypertension, hyperlipidemia together, you get heart disease. And to depress you further, what we're also seeing is that there's a very tight correlation between left ventricular mass and BMI. So this is new data that's rising from cardiac MRIs. And they're showing us that adipose tissue is this low resistance tissue in terms of blood flow. So you're constantly getting this high volume, high chronic overload state to the heart in terms of just having extra adipose tissue. There's also a very nice correlation between obesity and dementia and Alzheimer's, osteoarthritis, lots of knee surgeries, hand surgeries. There's also a very nice correlation between obesity and obstructive sleep apnea. In fact, over the last decade almost, we've just seen sleep medicine rise as a field. And in my practice, I started by aiming for a very cost-effective strategy and looking at which are the patients that should be tested for sleep. Now I test everyone. And it's really because when you have a BMI of 50 or you're approaching that BMI, we're looking at 1 in 2 individuals has sleep apnea. So it's just that prevalent. So with this, and I cut out some news headlines, and this is the first time we're looking at a generation of individuals that are going to have a shorter lifespan than their parents. And so that's quite troubling, and it makes sense if we look at now the mortality data. This study I really like. It was from the cancer prevention trial, and it allowed us to tease out just what an impact obesity has. So if we ignore those individuals who are smokers or have any other medical problems, and then we follow them, you can see that depending on their BMI, their risk of death increases exponentially. And this is for men beyond 30. And it seems for men, the lowest BMI is between 23 and 25. For women, similar data, but you start to see some numbers rising a little bit earlier. And for women, it seems the BMI, optimal BMI based on this study, is a little bit lower. To present this in another way, this study kind of brought in this point home. if we look at years of life lost in terms of obesity. So if we look at a white male who's age 20 and has a BMI of 45, something we actually commonly see now, they will take 12 years off of their life. If we stratify this by age, something interesting starts to appear. The impact is not that much when we look at our 70-year-olds. And if we look at a black male who's in their 20s and they have a BMI more than 45, we see that they've taken almost 20 years off of their life. So pretty dramatic. But if we look at this data in terms of a 70-year-old, we start to see something very interesting. And this is what has brought on the term obesity paradox. Because in these individuals, as you're going beyond a BMI of 30, you're actually getting a benefit. They're gaining life by having that higher amount of weight. So this is the first starting point in trying to consider a medical nutrition therapy regimen or anything for our obese patients, in that by having an obese patient above the age of 70 lose weight, are we actually doing more harm? As you can see here, the hazard ratio is actually increasing in lower BMIs. And if we put this together with the other study that looked at a younger population, mainly in their 40s and 50s, you can see what a dramatic difference this is. So when I started looking at this data, I took a step back at this point and said, this doesn't make any sense. We know obesity is bad. There's all these studies showing it, but why is it not that bad for our elderly? Why is there such an obesity paradox? And if we take a look at what are the body composition changes that are occurring as we're aging, some of this data starts to make a little bit more sense. So first, if we look at weight change by age, we start to see that as we get older, we gain weight. And this trend typically continues well into our 50s and 60s. And then at that point, we start to lose weight. But what's actually happening is our fat-free mass, our muscle mass, our lean tissue reaches its peak at the age of 20 or 20s. And then beyond that, we start to lose it quite dramatically. So by the age of 70, we may lose up to 40% of our fat-free mass. On the other hand, fat mass continues to increase. And it continues to do so until our 60s. So what's happening is not only are we gaining weight, but we're net gaining fat and losing fat-free mass as we age. Kind of depressing. But what's also happening, and many of us have noticed, and I've started to notice also, is that not only are we gaining fat mass, we're storing it in the wrong places. So it's all going in our bellies. And this happens across, white males or Asian, across all cultures. And what's the most troubling behind this is not only are we gaining abdominal fat, we're also gaining more and more visceral fat. So the ratio of how much of this fat is being deposited subcutaneously versus viscerally dramatically changes as we age. And so this is happening in both men and women. And in fact, women seem to be protected from this until menopause. And then the rate for men and women are roughly equal. But a picture is worth 1,000 words. So if we look at this fantastic study and we see two individuals who have a waist circumference of 36, you can see that the 37-year-old has a dramatic amount of subcutaneous fat and not that much visceral fat. The 82-year-old, it's completely reversed. So you can see what an impact it has, and we all know how detrimental visceral fat is. So this is a troubling sign. So then, when we go back to looking at the obesity paradox and try to think and come up with some hypotheses as to why it seems that weight is actually protective in these individuals, some of the questions we raise is that could it truly be protective? Maybe we're just seeing a phenomenon here that's true in elderly. Another hypothesis is that could the individuals who are more prone to the comorbidities have died off earlier. So by the time we selectively look at a population over 70, we've selected out people who are prone to die from, the detrimental effects of obesity. And so the people that are left in their 70s and 80s should really be encouraged to gain weight? Or is it that we're looking at the wrong thing in our elderly population? And that's additional studies then done in the 2000s seem to point at that, because they really then tried to stratify different aspects of obesity, and that's what we started to see. So if we look at and try to stratify the death rate by waist circumference, and we look at individuals who have a very high waist circumference at the highest risk, you can see that BMI does not make that much of a difference. Whereas if you take obese individuals and compare someone who has a very low waist circumference to that who has a high waist circumference, you can see what a big difference it makes. And it seems not only should we be measuring waist circumference, but perhaps we should really be measuring the waist to hip ratio. And many other studies, and I've just included this one, also showed very similar data. That perhaps it's not an obesity paradox, but perhaps we're just measuring the wrong thing. And it should really be a common practice in our clinic, such as now we have pain as a vital sign, that perhaps waist to hip ratio in our patients should also be a vital sign. And another fact, then there were a lot of studies, and I left those out for the sake of time, but there were a lot of studies that looked at a general population and following them saw that those individuals who actually lost weight had a higher risk of mortality, had worse outcomes. So based on that, there were additional studies done that looked at why these individuals lost this weight. And so if we tease out those people who got ill or lost weight unintentionally, you started to see right away that it was in fact, those are the ones that are causing this obesity paradox. Those who lost weight for personal reasons actually benefited quite a lot. So with this now, putting it all together, most of us feel that it is acceptable and beneficial for our patients to lose weight. And in fact, the most beneficial may not be just weight change, but maybe fat loss. So that's become the new strategy, is to focus on fat loss with the retention as much as possible of lean tissue. And so just kind of summarize, and I put this in here in case anyone was sleeping, but no one is. I'm very impressed. So, we've gone over what we're facing over the next 10 to 20 years in terms of obesity. It's going to become a problem for every healthcare provider, pretty much. We've also seen what detrimental health effects obesity has. We've gone over kind of the obesity paradox and seeing some of the data, the earlier studies showing that perhaps obesity is beneficial. And then we looked at why that seemed to be. And in fact, really with the obesity paradox, instead of weight loss, perhaps we should be aiming for waist loss. So with that, the next part of the talk, I'll switch to some of the data that's available for elderly in this regard, focusing on first medical nutrition therapy, and then switching to the drugs that are available, with 2 of them just coming to market, and then bariatric surgery. And so if we look at the first part of medical nutrition therapy, we're trying to preserve muscle mass. So we really want to target protein. And this is, again, where there's a lot of controversy. The RDA recommends a ratio of 0.8 grams per kilogram per day for adults over the age of 19. And so this is based on studies done very early on in people in their 20s. But is it the same for the elderly? Is this too much? We do want to preserve muscle mass. That's our optimal goal. But we know renal function in these patients is not the best. So is this too much? What we also know is that as we age, our fat mass increases and our fat-free mass decreases. So is this ratio too high for these individuals who have less fat mass? So this study aimed to examine this even further, and I thought it was a fantastic study. They actually took individuals a little younger than we would have liked, but they were still in their 60s with a range going out, or at least the standard, that was the range, going out into the 77. Still a little younger than what we typically see now. And they actually provided them meals. And so there, they provided them with eucaloric diet, but aimed to give them 0.8 grams per day per kilogram of protein. And then they did nitrogen balance studies. And what they started to see was that this wasn't enough. These individuals within weeks started to have negative nitrogen balance. And with that, you could actually see statistically significant changes in terms of their muscle mass. And there was a very nice correlation between negative nitrogen balance and how much muscle mass they lost. So with that, there were a lot of other studies done, and I put this in for your reference to look at how much protein really a lot of these individual studies were then recommending. Some even went as high as saying 45% of the energy should come from protein. Others went as high as 1.6 grams of protein per kilogram of body weight per day. So there's a wide range of recommendations. And other studies looked at the distribution of protein and really felt it was better to provide this protein on a nicely distributed manner instead of eating carbohydrate followed by steak for dinner. That seemed to be not the best strategy. And so if we're adding supplements and things like that, we should think about providing them earlier, as most people's breakfast typically tends to be protein deficient. So with that, we had some great recommendations about protein, but we still didn't know how many calories to recommend and whether there were studies done in the elderly. And again, this is just a fantastic study from the New England Journal that looked at this exact topic. And what they did was they studied 3 different approaches. They looked at providing these individuals with a diet that was deficient in calories by about 500 to 750 calories, as well as had 1 gram of high-quality protein per kilogram of body weight. They also compared this to exercise, and with the exercise, they focused on about 90 minutes of exercise 3 times a week. And they did this with a combination of stretching, a combination of aerobic exercise, and resistance training. So really wanted to target all 3 of those aspects. And then they combined the 2. So again, fascinating results. They did this over a year, and they found that you could lose and sustain that weight loss, at least while they're in the study, of about 10%. So they on average lost 9.7 kilograms. But this is what's troubling. They also lost lean mass as well as fat mass. With the exercise group, didn't really have that much weight loss. But you can see that they're gaining lean muscle mass and losing fat mass. But the best results, at least in terms of that lean body mass to fat ratio, seem to be in the combination. So with diet and exercise, we still lost a substantial amount of weight. We lost lean muscle mass, but in terms of comparing it to just the diet alone, it was a lot better. And then we still lost a substantial amount of fat mass. And this ratio seems to be the best because when they compared their physical fitness afterwards, it seemed that the diet and exercise group was the best. And so both in terms of physical fitness and this test, essentially there were a lot of things like standing up from a sitting position, chair test, stair test. So a lot of those kind of factors, and the individuals who went through diet and exercise did the best. Same with their cardiorespiratory, as well as their functional status. So it seems combination of diet and exercise is the best. Again, this one I just placed there for the handout for your reference. This study, instead of aiming for a caloric deficit, actually used supplements in combination with exercise. I like this study because it again targeted some of the higher age group in their 80s. And they compared leg strength, and this is what they saw, that the best outcome was again in those individuals that had exercise plus the supplement. So again, when we see these patients, looking at all of the data now, we can safely aim for waist loss, essentially loss of fat mass with hopefully a retention or preservation of fat-free mass. We see that a diet, many studies have now shown this, of 500 to 750 calories in our obese, BMI greater than 30 patients is okay. We should focus on protein and ensure they're getting about at least 1 gram of high-quality protein per kilogram of body weight. I couldn't make any recommendations higher because those other studies were just too small for us to then make higher recommendations, even though perhaps if we do better studies, maybe it should be 1.6 or even higher. Exercise-wise, we should recommend stretching, aerobic activity, as well as strength and resistance training, all three. And then we always recommend a multivitamin with minerals, focus on calcium and vitamin D. And vitamin D is a whole other issue that I'll skip very quickly. Then we get to pharmacotherapy. And this, until just this summer, was really almost a dead field. I mean, we really didn't have any drugs to give to patients. The one drug we had was orlistat, which is a lipase inhibitor and typically works by reducing about 1/3 of the dietary fat uptake. So the way in my practice, I do use it quite a bit, and the way it seems to work is that most patients first start by focusing on medical nutrition therapy. They focus on their diet, they make changes. The ones who've made changes, then I will go ahead and prescribe orlistat. They'll follow those changes until, let's say, one day they'll decide to have pizza, and they'll spend the next few hours on the toilet. And then either they'll continue the orlistat and quit the pizza, or they'll quit the orlistat. And that's 90% of the cases. So I still use it quite a bit, and as you can see, in addition to typical medical nutrition therapy, we are gaining an additional weight loss. Again, the troubling part is all of the studies have been done in younger people. So it's hard for us to extrapolate. Seems to be safe. The main issues seem to be, again, aside from the GI side effects, are vitamins. So some of the fat-soluble vitamins. So we follow those ahead of time and make sure they're replete before we start, and then we follow them for a few months to make sure there's not a dramatic drop. Sibutramine used to be on the market, but it was pulled off, and I'll show that study. Now we've got 2 other drugs that have been approved. One is a combination of Phentermine, and Phentermine actually is still on the market. It's on the market at a dose of about 37.5 milligrams per day, and it's been designed and kind of recommended by the FDA to use it for short term. And the inset really says a few weeks. Then Topiramate, so Phentermine and Topiramate is a new combination that's being introduced. Topiramate is a drug that's been out there, and it has 2 indications. One is 100 milligram per day dose for prophylaxis for migraines, and then there's an epilepsy dose that's 200 to 400 milligrams. And I'm just going into doses not to bore you, but to kind of show you that the combination is actually using a lot lower dose than what we've been doing in clinical practice. So you can see this is one of the first trials that was conducted. And this was really conducted in those with a BMI more than 35, but without significant comorbidities. So they were eliminating individuals who required multiple medications for hypertension, required insulin for diabetes, or even had a ton of medical problems. I think it was more of a proof of concept type study. So this one compared 15 milligrams of Phentermine along with 92 milligrams of Topiramate with a low dose version that was only 3.75, so 1/10 of the dose, and 23 milligrams of topiramate, so about a quarter of the dose. So dramatically lower doses versus placebo. And again, the big issue for us is the age. And most of our clinical practice, we're not seeing these many young people. Most people are in their 50s and so on. So it's again hard for us to extrapolate this data to the elderly. But we can see it had dramatic results. So you're gaining about 10% weight loss in addition to providing medical nutrition therapy. So all three groups actually got cognitive behavior therapy based on the Learn manual. And this is something we use at Mayo to prepare our patients for bariatric surgery. So it's based on the Learn manual. In addition to this, they were advised on a diet that was deficient in, again, about 500 to 750 calories. So dramatic weight loss, and these are kind of the magic numbers that we look for, because we know if we hit about 5 to 10% weight loss, we're going to see a dramatic improvement, hypertension, diabetes, all of these things. And in about 2/3 of the patients, we saw at least 5% weight loss in the higher dose, and about half achieved 10%. So fairly significant. Then finally, but that was in patients that I don't see. I don't see anyone who's just a healthy 50-year-old with obesity. You know, they all have a number of other medical problems. And so the Concur trial then enrolled these individuals. So they were looking for people who had high blood pressure, because that's always a big concern with Phentermine. They were looking at a number of individuals who had high blood pressure, who had diabetes, all of these things. And then the sequel trial, so this was done over 1 year. The sequel trial, which I'll present, was done over, they took all of the patients in the Concur study and then enrolled them into the sequel trial. And so we got 2 years of data. And with that we saw, and again, one other thing to point out is that this time the lower dose was a bit higher. So it was still lower than what we're used to. It was 7.5 milligrams and 46 milligrams of Phentermine, of Topiramate. So this time we see that there is still continued benefit. And I was very surprised to see how much of an impact the lower dose had. I mean, that's still dramatic weight loss. And again, it was designed the same way. They all got cognitive behavior therapy as well as dietary instruction. And this is something we all worry about is in these agents, because Phentermine will tend to increase norepinephrine in the hypothalamus, and that's how it produces its satiety effect. So we always worry blood pressure, but we saw, and this seems not more related to the drugs, but more related to the weight loss, but despite all of that, the blood pressure didn't increase. It actually went down. Same thing, we saw benefits in terms of lipids as well as diabetes. So the other drug that's coming out is Lorcaserin. And this is a selective serotonin receptor agonist. And this is somewhat related to a more non-selective agent, fen-phen. So instantly we're all just worried and just, we want to avoid it. But I'll just present the one study I was able to find. And this is a fairly good study. And again, randomized these individuals to medical nutrition therapy plus placebo or Lorcaserin, or Lorcaserin. And we see not as much weight loss as we saw with the combination of Phentermine and Topiramate, but still pretty substantial. And they actually did echocardiograms before and after, but this was only for 1 year. So in those individuals, we see that there is no change in terms of valve disease or any of this. So this is kind of the big study that worries us quite a bit. We had sibutramine on the market for a very long time. I used it quite a bit. It was very effective. But unfortunately, when finally a long-term study was conducted looking at cardiovascular events, we saw that even though the sibutramine group lost more weight, they actually had worse outcomes. So based on this trial, I think most people who practice in terms of medical nutrition therapy, especially in drugs, we're still cautiously optimistic. So even though these 2 drugs are coming on the market, we're very excited because this is something our patients desperately need, that little boost of appetite suppression. But we just don't know the long-term data. So at this point, I couldn't really make any recommendations regarding the new drugs, especially since all of the studies have focused on younger patients. So this is to be determined, essentially. Then in terms of bariatric surgery, we're doing pretty good on time. So last few slides. In terms of bariatric surgery, this is something that's also dramatically increasing. We're seeing well over 250,000 procedures in terms of bariatric surgery being done in the country on a yearly basis. In our practice at Mayo, we're starting to see older and older patients. So each year, it seems the number of individuals older than 65 is rising dramatically. And right now, before I came, I looked at the last statistics, and we're running between 10 to 12% of our patients are now greater than 65 and getting bariatric surgery. And all of the studies pretty much seem to show the same thing. These individuals tend to be sicker and have less efficacy with bariatric surgery. So they seem to lose less weight, and they seem to have less resolution of diabetes, less resolution of hypertension, and less resolution of hyperlipidemia. But we're still, gaining a great deal of benefit, and so still would recommend bariatric surgery as sort of that last resort. And I've included this other study that essentially, so these were the 2 major studies that I saw looking at this population, because there's literally probably 4 studies total in terms of bariatric surgery that have looked at this. And this study also showed exactly the same thing. So I've included that in your handout. So overall, just to kind of summarize everything, we've seen dramatic rise in obesity. And unfortunately, unless there's some big changes, which probably won't happen yet, the next few decades for us in healthcare are quite troubling. We've seen the mortality data, how detrimental obesity is in terms of everything. We've gone over kind of the obesity paradox, and I personally do believe that we are measuring the wrong thing, and we should be focused on the waist to hip ratio in many of our elderly patients. And the emphasis should really be on retention of fat-free mass and loss of fat mass, waist loss. And I think based on the data that's out there, these are fair recommendations that we can all make to our patients with a modest reduction in energy intake. We initially typically will start by looking at, and we use the Harris-Benedict calculator. So we'll look at their basal caloric requirements, add 20%, and then reduce that by 500 calories. And that'll be our recommendation for calories per day. If they come back in a few months and they haven't hit their target weight loss or haven't lost any, we do then recommend going down to 750. In terms of diet, we've been emphasizing 1 gram per kilogram of high quality protein for pretty much everyone in that range if they have fairly good renal function. And then we also highly emphasize exercise. I think that's one of the biggest components. And most of our programs have stretching and aerobic exercise built in, but we also emphasize strength and resistance training as well. Multivitamins, like I mentioned. And then in terms of medications, I've used orlistat in some of my patients, and they've actually done quite well. Phentermine, Topiramate, and Lorcaserin, we're still optimistically cautious, but the data isn't out there to make any recommendations. Bariatric surgery seems to be effective, not as effective as what we're seeing in our younger patients, but they still have good resolution of diabetes and a lot of the other comorbidities. So we do quite a bit of these. I think overall, we're doing more than 400 cases, so typically in a year, 40 to 50 will be in patients over 65. So thank you.
You mentioned the phrase high-quality protein a few times. Are we talking about like steak versus cockroaches, or can you clarify?
Yeah, I mean, I think we just emphasize exactly that. When we're making recommendations in terms of diet, a lot of patients will consider protein in a number of ways, and steak may not be the best option. So a lot of my patients will emphasize things like yogurt, as breakfast options instead of eggs and bacon. So things like that, I think, are what I recommend as higher quality, where you're not also getting a lot of the trans fats and those kind of things. And that makes a big difference, just making those small changes to what they're used to eating for breakfast.
And on the subject of trans fats and protein, in medical school, which was 100 years ago for me, there was a comparison, I remember, of Seventh-day Adventists versus Mormons, because randomizing people to a diet was difficult, and most Seventh-day Adventists, from what I know of it, are vegetarian, and they outlive the Mormons, who, like the Seventh-day Adventists, wear their seatbelts and don't drink alcohol and what have you. Yeah. So any thoughts on the nutritional advantages or disadvantages of vegetarianism, and do you ever discuss that with patients? Your thoughts?
Yeah, that one is almost impossible in the Midwest. I just, I haven't seen many patients that will actually, that are vegetarian. There haven't been any direct studies. A lot of the animal products, when they do those kind of studies, if you're using a lot of animal meats and things like that, the diet is worse. And the outcomes are worse. So vegetarians tend to do better. But our main focus is to, and this is almost a new emphasis that we've implemented over the last few years, is almost motivational, therapy. When we see these patients, if you recommend drastic changes, we just don't get results. So we almost focus on whatever diet they're on, whether it's vegetarian or completely meat-based, and we ask them what are changes they're willing to make. And so it seems if they come up with the idea and saying, and you can have pictures of yogurt there, but it seems if they go, maybe I'll try yogurt, and you say, oh, that's a brilliant idea, they're more likely to carry that out than if you say, here, eat this. So our focus has really been on working with what they're doing right now and then making small changes.
A lot of my patients can't tolerate Topamax, even in the younger groups, because of cognitive problems with it. Did you notice that in the study, or were you part of that study?
No, I wasn't part of that study. That was some of the side effects, and it seems that that's why they went to a lot of the lower doses. But they were still there were still side effects, such as even depression, that was reported as more in the treatment group than the non-treatment. And this is again the problem, and that's why we're very cautious, because when you go from 300 individuals or 400 to then applying it to thousands or millions, that's when you really see what an impact it has. And I would still shy away from giving those drugs until we know and get more data in terms of especially the elderly. Yeah.
Why the relationship between dementia and obesity? Is it more activity related?
It could be activity. A lot of theory, and this is about, this is going out a little bit outside of my practice, but there's also the more you seem to eat, and that went into the concept of, it seems that the less we eat, the longer we live. And this could be the free radical formations and a lot of the plaque formations in terms of neurons that could be contributing to this. So those who overeat are getting more and more destructive processes in their neurons and buildup of the plaques that cause Alzheimer's. So there's a lot of theories out there, but there isn't anything proven. Activity, and I think also the main factor seems to be that those who tend to follow a very nice, strict diet also tend to be more academically oriented, and tend to challenge themselves more. And perhaps all of these things are in combination leading to less dementia. But there's a lot of theories, but nothing substantial yet.
Sorry for being a microphone hog here.
Please.
I've been interested, I think we all have been interested in this science of telomeric length and longevity. And I know there's some very solid animal data on hunger and what the physiologists call the near starvation diet. I've sent some of my morbidly obese patients off to nutritionists, and they came back to me telling me that they were told to eat 5 meals a day, not 3 meals a day, which for me, is a forehead slapping, moment. Can you speak to that at all?
Absolutely, and this is, a forehead slapping, going, oh gosh, because it's a widely prevalent notion of eating 5 meals a day or 5 smaller meals. The problem again becomes reality. Our patients seem to not be able to snack. They're not going to count 10 almonds and snack. They're going to eat fistfuls, and so they're really starting to get 5 meals per day. So in our practice, we absolutely cannot implement 3 meals and 2 snacks. There's a lot of data that's looked at, this and trying to preserve the metabolism. There's all this data out there, but then the reality is if you tell an individual to eat 3 meals and then put in 2 snacks, those snacks are meals and there's no weight loss. And so absolutely, I'll sit there and I'll say, what are your snacks? And they'll say, oh, I'll snack on some peanuts. And they've gone through a box, which ends up being 500 calories. So yeah, in my practice, it's 3 meals a day with minimal to no snacking. And sometimes we'll say, okay, since you cannot make it to lunch, add a banana, and we'll tease through that. But otherwise, yeah, they're just going to eat 5 meals.
Can you speak to the utility or maybe the lack of evidence or supportive evidence regarding fasting? I'm familiar with a little more anecdotal human stuff on that, but my gut is based on animal data that fasting is probably a good thing for us. Do you have any luck talking people into missing meals? Is that, obviously if they're on some diabetes drugs, you don't want them skipping meals, but for the rest of us?
And the fasting issue we also don't recommend. So that's also, there is data. If you go back to the caveman day, the data that you're referring to is that we're kind of designed not to eat 3 meals a day every day. We may eat once a week. But there's also data regarding the impact of this in metabolism. And this was actually done in USC in the 50s, where this is pre-IRB, where they convinced homeless people to come and spend the week and would feed them and then just follow their thyroid levels. And so they started to see that the skipping of a meal within 12 to 18 hours, you immediately started to get a reduction in T3 levels. So the metabolism starts to slow down essentially if we skip breakfast. So typically our practice will recommend 3 meals a day and not recommend fasting because of that impact on metabolism. So, and a lot of our patients were preparing for bariatric surgery, where the issue then becomes protein intake and all of these things. And that also, the skipping of meals has a very detrimental effect. So we don't recommend fasting. But, there is data, absolutely. And there was a huge study showing people who were chronically, and this was from the monkeys, that were chronically energy deprived lived much, much longer. Yeah. Good, well, thank you. Perfect timing, 1 o'clock.